Welcome to the Deep Dive. Today we're really getting into the heart of modern healthcare, how we manage and, well, understand all the data that drives pretty much everything.
Yeah, it's fundamental.
Whether you're a healthcare professional dealing with complex rules, maybe a student just building up your knowledge base, or, simply curious about what goes on behind the curtain, this one's for you.
Think of it like getting a backstage pass.
Exactly. Seeing how information shapes patient care makes systems more efficient. Our goal today is to really boil down the essentials from a big 15-week graduate lecture series. It's called Healthcare Data Management and Statistical Analysis.
Right. It's designed for folks going into healthcare administration, public health, biostatistics, future leaders, basically.
But we're going to pull out the key insights, make them clear, relevant, maybe even a bit surprising.
That's the plan, because this isn't just about, numbers for the sake of numbers. It's about understanding what actually helps improve healthcare.
Better outcomes, more effective delivery.
Precisely. We'll look at the main modules from the course, zero in on what's most critical, and hopefully make some of these sometimes complex ideas really click.
Okay, so we've broken this semester-long course down into 4 main areas for our deep dive today. First up, consent and patient information.
Yeah.
Really foundational stuff, IPA, ethics, all that.
Crucial. Couldn't start anywhere else, really.
Second, we'll explore the different types of data in healthcare. Knowing what kind of information you have dictates how you handle it.
Categorical, continuous.
Yeah.
It matters.
Third, measures of central tendency. Finding the average, the middle, the typical value, cutting through the noise.
Mean, median mode. The classics.
And finally, we'll get into data validity and specificity. Basically making sure the information we're using is actually accurate and tells us what we think it tells us.
Super important for trust and good decisions. Each area, like you said, has some really practical takeaways.
And guiding us through all this is the expertise baked into the source material from Dr. Mazen M. Salama. He authored this lecture series.
Right, and his background is perfect for this. He's a senior clinical data scientist, a quality consultant, and a practicing cardiologist.
Wow, so he really sees it from both sides, the patient care and the data analysis.
Exactly. Plus, he wrote a CPHQ certification prep course, founded companies like Tom SE and Datamia focused on quality management and data. I mean, he really gets how data drives quality improvement. He's that bridge between medicine and data science.
Okay, fantastic. Let's dive right into that first module then. Consent and patient information. You called it the ethical and legal foundation.
Absolutely. Patient consent isn't just, signing a form. It's a core legal principle, an ethical must-have. It protects the patient's right to choose their autonomy, safeguards their privacy, and, crucially, keeps healthcare providers compliant with laws like KEY.
KEY, everyone's heard of it, but maybe let's unpack why it's so central to managing patient info.
Right. IPI stands for the Health Insurance Portability and Accountability Act, passed way back in 1996, but it's been updated quite a bit since then. The latest updates, up to 2025, really grapple with digital health, cybersecurity threats, making sure patients can get their data.
So it evolves with technology.
It has to. At its core, IPA deals with protected health information, or PHI. That's any health info that could identify someone's medical history, lab results, even billing info.
Yeah.
And importantly, IPA covers this whether it's electronic, on paper, or even just spoken.
Okay, so what are the main mechanisms IPA uses to protect this PHI?
Well, there are a few key parts. The privacy rule is a big one. It limits how PHI can be used and shared. Generally, it's allowed for treatment, payment, and healthcare operations. You often hear that called TPO.
TPO, got it.
Yeah.
The essential functions.
Exactly. Then there's the security rule. This focuses specifically on electronic PHI, or ePHI. It mandates safeguards things like encryption, access controls.
Like needing a password and a code from your phone.
Multi-factor authentication, yeah. That's a common one. Plus, keeping audit logs detailed records of who accessed what information, when. And finally, IPA gives patients rights. Big ones, like the right to access their own records, ask for corrections, and know who their information has been shared with.
And if organizations don't follow these rules, the consequences can be serious.
Oh, absolutely. By 2025, we're talking fines up to $2 million for a single incident. It depends on the severity, of course. And cybersecurity is a huge piece of this ransomware, was behind something like 70% of healthcare breaches in 2024. So the need for strong security is constant.
Can you give a really clear example? When is sharing okay under TPO, and when do you absolutely need specific permission?
Sure. Think about your doctor sending a claim to your insurance company. That's for payment, right? Falls squarely under TPO, no extra authorization needed. But let's say a hospital wanted to give a drug company a list of patients with diabetes for marketing a new drug. That's not TPO. They would need explicit written permission authorization from every single patient on that list.
Big difference.
Huge difference. And mistakes are costly. There was a case in 2024, a clinic got hit with a $1.5 million fine. Why? Because they sent emails with patient records that weren't encrypted. A direct violation of the security rules requirement to protect EPHI.
So staying compliant is an active process. What's new in how we manage this? Any advancements?
Yeah, there are some positive steps. The adoption of FHIR, that's FHIR, Fast Healthcare Interoperability Resources, has been significant.
FHIR, what does that do?
Think of it as a standard digital language. It lets different healthcare computer systems, EHRs, apps, etc., talk to each other and share data securely and much more easily. Huge for interoperability. By 2025, something like 95% of U.S. hospitals are using FHIR standards.
That's widespread.
It is, and we're also seeing more AI tools designed specifically for HIPAA compliance. They can automate audits, spot potential security risks. Some studies show they cut down compliance errors by around 40%.
Okay, so HIPAA provides the overarching rules.
Yeah.
But what about the actual asking the patient, getting their agreement for treatment or using their data? Are there different kinds of consent?
Yes, definitely. We generally distinguish between two main types. General consent and special consent.
General consent. Is that the paperwork you fill out when you first go to a new doctor or hospital?
Pretty much. That usually covers the routine parts of care. Allowing different doctors involved in your care to coordinate, letting the hospital use your info for billing and those core healthcare operations, the TPO stuff we mentioned.
So sharing diagnosis codes with Medicare for billing, that's covered by general consent.
Typically, yes. It's often handled electronically now, integrated right into the EHR system during registration. Although it's interesting, a 2024 survey found nearly a third of patients don't really understand the full scope of what that general consent covers.
Yeah, those forms could be dense. So that's general consent. When does special consent come into play?
Special consent is needed for things that are, well, more significant. Higher risk medical procedures, surgeries, participating in clinical research trials, things like that. The process has to be more detailed.
And who explains it?
Usually the practitioner involved the surgeon, the researcher, the specialist. They need to explain the specific procedure, the risks, the benefits, alternatives. And critically, the exact legal requirements for how you get special consent can actually vary from state to state.
Oh, really? It's not the same everywhere.
Nope. California, for instance, might require both a verbal explanation and a signed written form for certain things. Texas might just mandate the written form. You have to know the local rules.
Can you walk us through an example of special consent?
Sure. Let's say a patient needs angioplasty. The cardiologist would sit down with them, explain the procedure, talk about the potential benefits, but also the risks, like, say, a 2% chance of stroke associated with the procedure. They discuss alternatives, maybe medication. Only after the patient understands and agrees would they sign the special consent form.
And technology's changing this too.
It is. E-consent platforms are becoming more common. They can present information clearly, sometimes interactively, even in multiple languages. We saw data in 2024 suggesting these platforms boosted compliance, like getting forms fully completed by up to 50% in some places.
You mentioned state law variations. How might those differences play out practically for a patient?
They can have a real impact. New York, for example, has a rule requiring a 24-hour waiting period between getting informed consent and having most elective surgeries. Gives people time to think it over.
Interesting.
Right. Or think about minors. Florida has very specific laws about needing parental consent for procedures on kids, except in true emergencies. There was even a lawsuit down there over a non-emergency procedure done on a minor without parental consent. So knowing and following state law is absolutely critical.
This brings us neatly to informed consent. Sounds like it's more than just getting a signature. What does it really mean?
It absolutely is more than a signature. Informed consent is about process. It's ensuring the patient genuinely understands the treatment they're agreeing to, the risks, the benefits, the alternatives, so they can make a decision that's truly voluntary and based on reason. It's paramount for those higher risk special procedures we talked about.
So what absolutely needs to be covered in that conversation and documented on the form for it to be considered informed?
Several key things. First, the name of the actual procedure, total knee replacement, not just knee surgery. Then, a clear explanation of the likely risks and benefits. And that includes not just common risks, but potentially serious rare ones too, like maybe a 0.5% risk of a specific complication.
Okay.
Also, realistic alternatives need to be discussed. What happens if they choose medication instead? Or physical therapy? And importantly, what are the risks of not having the treatment? Maybe the condition gets worse. Finally, you need the signatures patient or the representative, usually a witness, date. And like we said, some states add extras, like acknowledging that 24-hour wait in New York.
Can you paint a picture of how this might work in practice, maybe for a surgery or a clinical trial?
Okay, imagine a neurosurgeon explaining a brain tumor resection. They detail the surgery, the potential benefit removing the tumor, but also the risks, maybe a 5% chance of some cognitive impairment. They'd also discuss radiation as an alternative. Maybe they even use a VR simulation to help the patient visualize it. After all that, the patient signs.
VR, that's becoming more common.
It is. Studies show it can boost understanding. Another example, a clinical trial for a new drug. The informed consent process is exhaustive. It details all potential side effects, maybe a 10% risk of nausea, explains that they might get a placebo, outlines the study procedures, their right to withdraw, all following strict FDA guidelines.
So technology like VR and AI chatbots are really enhancing this.
They definitely seem to be helping. That VR data suggests a 35% jump in comprehension sometimes, and AI chatbots offering 247 answers to common consent questions. About 20% of hospitals were using those by 2025. Mayo Clinic even published work showing VR consent for spinal surgery reduced patient anxiety by about 25%.
What happens legally if a procedure is done without proper informed consent?
It's serious. Performing a procedure without valid informed consent can legally be considered battery, essentially, unwanted touching. There is, however, a critical exception, the emergency exception. If a patient is facing an immediate life-threatening situation and can't give consent, maybe their unconscious providers can give necessary treatment without it.
Okay, that makes sense. So we've covered when consent is needed. But are there times healthcare organizations can use patient PHI without getting specific authorization for each use?
Yes, and this comes back to that TPO framework under HIPAA treatment, payment, and healthcare operations. Certain uses and disclosures of PHI are allowed without individual authorization because they're essential for running the healthcare system effectively and ensuring quality and safety.
What kind of activities fall under that umbrella?
Things like quality assurance and improvement. Hospitals constantly analyze patient data, maybe looking at infection rates or readmission rates to see how they can improve care. That doesn't require signing a form every time.
Okay, what else?
Staff credentialing is another one. Hospital admin might need to review patient outcomes associated with a particular doctor as part of evaluating their performance. Infection control activities, like tracking hospital-acquired infections to stop outbreaks, and internal audits, like checking the accuracy of billing codes. These all fall under operations.
Can you give a concrete example? A hospital using PHI for quality improvement.
Sure. Let's say a hospital notices an uptick in surgical site infections after hip replacements. The quality improvement team could review the PHI of patients who got infections, looking at their pre-op health, the specific surgical techniques used, post-op care protocols. They do this without getting new consent from each patient under the quality improvement provisions of HIPAA to identify patterns and figure out how to reduce that infection rate. Maybe the rate was running at 10% in 2024, a clear target for improvement.
And it seems like using data for improvement is getting even more sophisticated.
Absolutely. We're seeing regulatory updates, like in 2025, clarifying how de-identified PHI can be used for AI-driven predictive analytics. The goal is proactive safety, using AI to spot patients at high risk for, say, falling or developing complications so staff can intervene earlier. HHS projected this could boost patient safety by maybe 15%.
Is there a case study for that?
Yeah, a good one from a Boston hospital. They used AI analyzing de-identified EHR data under these quality rules to predict which patients were at high risk of sepsis. By catching it early, they reduced sepsis mortality by 20%. It shows the power, but also raises questions.
Like, how do you balance this need for data with patient privacy?
That's the constant tension. De-identification is key, stripping out anything that could link the data back to a specific person. Techniques for doing this are getting better, and by 2025, estimates were that around 80% of hospitals were using some form of de-identification for analytics. It's a critical piece of the ethical puzzle.
Okay, that's internal use. What about sharing PHI outside the organization?
That's external disclosure, and the general rule is stricter. You usually need specific patient authorization. But again, there are exceptions, mostly for public health and legal requirements.
What are those exceptions? When can data be shared externally without authorization?
Legally mandated reporting is a big one. Hospitals have to report births, deaths, and certain communicable diseases like TB or measles to public health agencies like the CDC. That doesn't require individual consent.
Makes sense from public health.
Right. Also, in emergencies, sharing necessary info with paramedics or another hospital if a patient is transferred. And for research, if the data is properly de-identified and the study is approved by an institutional review board, IRB. A simple example. A hospital reporting weekly flu case numbers to the state health department. That's routine public health surveillance.
So if it's not one of those exceptions, you need formal authorization. What has to be in that authorization form?
It has to be very specific. It needs to state exactly what PHI is being shared. For example, MRI report from Juneteenth. It needs to say who is allowed to receive it. For example, Dr. Smeek of the Oncology Center. It must state the purpose, for example, for treatment consultation. It needs an expiration date. It can't be open-ended, may be valid for 6 months. And critically, the patient signs and dates it, and the form must explain their right to revoke the authorization later in writing.
Any tech helping secure these external shares.
Blockchain is being explored quite a bit. Some pilot projects in 2024 using blockchain for secure PHI sharing reported about a 25% drop in breaches compared to older methods. Its secure, decentralized nature seems promising.
But breaches still happen if rules aren't followed.
Oh, definitely. There was a case in 2025. A clinic shared patient data with a third-party marketing company without getting authorizations. Big mistake. Led to $3 million in fines. It really underscores how carefully external disclosures need to be managed.
Okay, let's wrap up this consent module. Can you share maybe one or two case studies that really illustrate these points and any big recent regulatory shifts?
Sure. One interesting case, a rural hospital implemented an e-consent system using tablets. They saw a huge 60% drop in errors, missing signatures, incomplete forms, and patients reported higher satisfaction. Makes you think, how much did just having it in multiple languages help address equity issues?
Good point. Another example.
A children's hospital used VR to explain tonsillectomies, the risks, benefits to kids and parents. They found parental consent rates went up by 30%, which is great, but it also sparks ethical thoughts about using immersive tech for pediatric consent.
Definitely food for thought. And regulatory changes. What's new?
Well, 2025 saw HIPAA updates focused on improving patient access to their own digital health data, making it easier, faster. There's also a much more regulatory focus on AI, how patient data is used to train AI, requiring transparency and fairness. And globally, things like Europe's GDPR are influencing U.S. practices, especially in telehealth across borders, often demanding more explicit consent for data sharing.
It really feels like a pivotal time for data privacy and use. Any final thought on consent?
Just maybe reflecting on how AI will continue to change things, not just analysis, but maybe even the consent process itself. How do we get informed consent for data use by an algorithm that's constantly learning? It's something we'll be grappling with.
Okay, let's shift gears to our second module. Types of data in healthcare. It's not all just numbers on a chart, is it?
Not at all. Data is the absolute bedrock of healthcare analytics. It drives decisions at every level, from a doctor figuring out a patient's treatment plan to policymakers shaping national health strategies. And fundamentally, most healthcare data falls into two main buckets: categorical data and continuous data.
Okay, categorical versus continuous. What's the essential difference?
Categorical data fits into distinct groups or categories. You count it. It's often qualitative. Think disease types like different kinds of cancer or patient gender. Continuous data, on the other hand, is numerical. It can, in theory, take on any value within a range. It's measured, it's quantitative, and it can have decimals or fractions. Blood pressure, height, weight, temperature, those are continuous.
Why is making that distinction so important in healthcare?
Because the type of data tells you what you can do with it, what kinds of questions you can answer, what statistical tools make sense. Categorical data is great for tracking how common things are, like finding that 20% of your clinic's patients have hypertension. Continuous data is key for monitoring changes, tracking trends over time, calculating averages, like seeing if a patient's cholesterol level is going down with medication, or figuring out the average length of an ICU stay.
Can they be used together?
Oh, absolutely. Think about tracking COVID-19. You'd use categorical data to count the number of cases, positive, negative, in different age groups. But you'd use continuous data to look at things like the average number of days until recovery or the range of viral load measurements.
And I guess the math we use is different too.
Totally different. For categorical data, you're often dealing with counts, percentages, proportions. For continuous data, you're calculating means, averages, medians, middle values, ranges, standard deviations. Even how you graph them differs. Bar charts or pie charts often work well for categorical, while line graphs or histograms are more common for continuous.
Okay, let's dig into categorical data a bit more. You mentioned two subtypes, nominal and ordinal. What separates them?
Right, so both deal with categories. Nominal data has categories with no inherent order or ranking. Blood types A, B, ABO, there's no logical sequence to them. Same with something like insurance provider names. Ordinal data does have categories with a meaningful order, but the intervals between the categories aren't necessarily equal or known.
Like a pain scale.
Exactly. A pain scale from 1 to 10, you know that 7 is more pain than 3, but you can't say the difference between 7 and 8 is exactly the same amount of pain increase as between 3 and 4. Other examples might be cancer staging, stage 1, 2, 3, 4, or patient satisfaction ratings. Very satisfied, satisfied, neutral, dissatisfied.
So for nominal data like blood types, what analysis do we do? Just count them up?
Pretty much. You look at frequencies and proportions. A clinic might report 40% type O, 35% type A, etc. You can use statistical tests like the chi-square test to see if, say, the distribution of blood types in your patient population is significantly different from the general population. And visually, a pie chart works well to show those proportions.
And with ordinal data, since there is an order, what else can we do?
Well, besides frequencies, you can look at cumulative percentages. Like 60% of patients reported their pain as 5 or less. Because of the order, you can also use different statistical tests, often non-parametric ones like the Mann-Whitney-U test, to compare groups. For example, comparing post-op pain scores between patients getting 2 different types of anesthesia. A 2024 study might have used ordinal patient satisfaction data to pinpoint specific hospital services needing improvement.
Are new technologies changing how we analyze categorical data?
Yes, machine learning is making big strides here. Algorithms like random forests or gradient boosting can handle lots of categorical input variables, diagnoses, procedures, demographics to predict outcomes like hospital readmission risk or likelihood of developing a complication. We saw reports in 2024 suggesting these models improved readmission prediction accuracy by something like 20% over older methods.
Okay, let's switch to continuous data again. Two subtypes, interval and ratio. What's the key difference there?
The big difference is the 0 point. Both interval and ratio data have equal intervals between values. The difference between 5 and 6 is the same as between 95 and 96. But interval data has an arbitrary 0. 0 doesn't mean the complete absence of the thing being measured.
Temperature in Celsius or Fahrenheit?
Perfect example. 0 degrees C doesn't mean no temperature. Ratio data, however, has a true 0. The 0 means absolutely nothing of the quantity being measured. Weight 0 kilograms means no weight. Height 0 centimeters means no height. Heart rate 0 beats per minute. Well, that's clear. Age, blood pressure, lab values like cholesterol, those are typically ratio data in healthcare.
How does that true 0 and ratio data affect what we can do statistically?
Because ratio data has a true 0, you can make meaningful ratio comparisons. You can say someone weighing 80 kilograms is twice as heavy as someone weighing 40 kilograms, or a lab value of 10 is half as much as a value of 20. You can't do that with interval data. 20 degrees C is not twice as hot as 10 degrees C in a physically meaningful way.
So what tests do we use?
For interval data, you often use t-tests to compare the average between two groups, like average temperature before and after a medication. For ratio data, you can use t-tests too, but also more complex analyses like ANOVA, analysis of variance, to compare averages across more than two groups, like comparing weight loss across 3 different diet plans.
Can you give a healthcare example using ratio data from a recent study?
Sure, a 2025 study might have looked at the effectiveness of a new insulin protocol. They could use blood glucose levels, ratio data, measured over time in different patient groups to see which protocol led to better glycemic control, maybe showing a 15% reduction in hyperglycemic episodes.
And technology. How's that impacting continuous data collection and analysis?
Wearables are huge here. Smartwatches, continuous glucose monitors, fitness trackers, they generate massive streams of continuous physiological data. Heart rate, activity levels, sleep stages, blood oxygen. By 2025, the accuracy for things like heart rate on some consumer devices is getting impressively close to clinical grade, maybe 99% accurate in some cases.
What would that allow?
It allows for much more granular, real-time monitoring and analysis. You can see trends in a patient's vital signs over hours or days, not just snapshots during clinic visits. This continuous stream is perfect for line graphs, visualizing how things like blood pressure or glucose levels change over a 24-hour period.
Okay, we understand the data types. Now, what specific tools do analysts use to crunch these numbers? You said the tool depends on the data type.
Absolutely critical. Using the wrong statistical test on the wrong type of data gives you garbage results. You need to match the tool to the job.
So for categorical data, nominal or ordinal, what are some go-to tools?
The chi-square test is a workhorse. You use it to see if there's a statistically significant association between two categorical variables. For example, is there a link between smoking status, yes, no, and developing a certain type of lung disease, yes, no. Another really useful one, especially for quality improvement, is the Pareto chart.
Pareto chart.
Yeah, it's basically a bar chart that ranks categories from most frequent to least frequent, often with a line showing the cumulative percentage. It helps you visually identify the vital few categories causing most of the issues, the 80-20 rule idea. A hospital might use it to see that, say, 80% of billing complaints come from just 20% of the possible error types, helps focus improvement efforts.
Makes sense. What about tools for continuous data interval or ratio?
The t-test is very common for comparing the average of a continuous variable between two groups, like comparing the average length of stay for patients who got surgery versus those who didn't. If you have more than two groups to compare, you'd typically use ANOVA. Another key tool, especially for monitoring processes over time, is the control chart.
How does a control chart work?
It plots a continuous measurement over time, like daily wait times, with upper and lower control limits calculated statistically. It helps you see if the process is stable and predictable, or if there are special cause variations popping up that need investigation. A 2024 hospital project might have used control charts to track wait times and demonstrate a sustained reduction, say by 30%, after implementing changes.
What software do people use for this? Is it all specialized stats packages?
While Excel can do basic things, serious healthcare analytics usually involves more powerful tools. The programming languages R and Python are dominant now. They both have huge communities and libraries specifically for statistics and data science. Things like Pandas and Scipy and Python are indispensable. By 2025, you'd find that the vast majority, maybe 85%, of healthcare researchers and data analysts are using R or Python or both.
Okay, let's talk AI. How is artificial intelligence changing the game for analyzing both categorical and continuous data in healthcare?
AI is really adding another layer of sophistication. It's moving beyond just describing data or testing simple hypotheses to building complex predictive models and enabling real-time monitoring in new ways.
How does AI tackle categorical data specifically?
Machine learning models like decision trees, random forests, or even neural networks can analyze patterns in categorical data to make predictions. For example, an AI could look at a patient's diagnosis codes, categorical, demographics, categorical, and past procedures, categorical, to predict their risk of being readmitted to the hospital within 30 days. A 2024 model might claim 85% accuracy in predicting heart failure readmissions using primarily categorical inputs.
And for continuous data, what are the AI applications there?
Here, AI techniques like time series analysis are powerful for forecasting trends based on continuous data streams. Think about predicting a patient's blood pressure fluctuations based on wearable sensor data, or analyzing continuous vital signs from ICU monitors to predict sepsis development hours before it becomes clinically obvious. There was a trial in 2025 using wearables and AI that reportedly predicted sepsis 6 hours earlier in some cases, which is potentially life-saving.
That's incredible potential. But are there challenges or ethical concerns with using AI on health data?
Absolutely. Big ones. Bias is a major concern.
Yeah.
If the data used to train an AI model reflects existing health disparities, the AI might perform worse for certain groups, like minorities, potentially worsening inequities. There's a big push now in 2025 to develop fairness algorithms to try and detect and mitigate this bias. Consent and privacy are ongoing ethical debates. How do we ensure patients understand how their data might be used to train these complex AI systems? Transparency is another challenge sometimes. AI models are like black boxes, making it hard to understand why they made a certain prediction, which can be problematic in clinical decision-making.
Can you give one more concrete example of AI's impact using data analysis?
Yeah, there's a case where a hospital system used an AI system to constantly scan EHR data, looking at both continuous data like lab results and vital signs, and categorical data like medication orders. It was specifically looking for patterns associated with potential medication errors. By flagging higher risk situations for pharmacists to review, they managed to reduce medication errors by about 40%. Real tangible impact on safety.
To make these data types really concrete, can you describe a sort of practical exercise someone might do, like that workshop idea?
Sure. Imagine a workshop scenario. Participants get a sample, de-identified hospital data set. It's got a mix, maybe patient diagnosis, categorical, nominal, patient satisfaction score, categorical, ordinal, maybe 1 to 5, length of stay in days, continuous, ratio, and body temperature on admission, continuous, interval.
What would they do with that data?
First, they'd have to classify each variable. Is it nominal, ordinal, interval, or ratio? That's step one. Then they'd create some basic visualizations, maybe a bar chart showing the frequency of different diagnoses, or a histogram showing the distribution of lengths of stay.
And then some analysis.
Right. They'd run appropriate basic stats, maybe calculate the mode for diagnosis, find the mean and median length of stay, perhaps run a t-test to see if average temperature differs between two diagnosis groups. They could use Excel or maybe basic R or Python commands. The key is applying the right technique to the right data type and interpreting the output. For instance, noticing the mean length of stay is much higher than the median might indicate some very long stays are skewing the average.
Great way to make it stick. Okay, let's move to Module 3. Measures of central tendency. Finding that middle ground in the data.
Exactly. Central tendency measures give you a single value that summarizes the center or the typical value of a data set. Hugely important for boiling down complex information. We'll focus on the main players: the mean, median, mode, and the weighted mean.
Let's quickly recap what each one tells us. Mean first.
The mean is just the arithmetic average, add up all the values, divide by how many there are. It uses all the data, which is good, but it can get pulled around by extreme values or outliers. You might use it for average cost per patient or average wait time. Best for interval and ratio data that's not too skewed.
Okay, median.
Median is the middle value when you line all the data up in order. If you have an even number of data points, it's the average of the two middle ones. Its strength is that it's not easily swayed by outliers. Great for skewed data, like income or hospital length of stay, where a few extreme values could throw off the mean. Mode is simply the value that shows up most often. It's the only measure of central tendency that makes sense for nominal categorical data, like the most common diagnosis or blood type. You can have no mode, one mode, unimodal, or multiple modes, bimodal, multimodal.
And weighted mean.
Weighted mean is an average where some data points count more than others. Each value gets multiplied by a weight reflecting its importance. You sum those up and divide by the sum of the weights. Used a lot in healthcare for composite scores like HCA, HPS patient satisfaction scores, where different domains might have different weights, or in calculating quality metrics for reimbursement.
You mentioned visualizing these on a histogram.
Yeah.
How do they relate in a typical distribution?
In a perfectly symmetrical, bell-shaped curve, a normal distribution, the mean, median, and mode all line up right in the center. They're identical. But if the data is skewed, they start to separate.
How so?
If it's skewed to the right, long tail towards higher values, the mean gets pulled highest by those extreme values, then comes the median, and the mode is lowest, typically at the peak. If it's skewed left, long tail low, it's the opposite. Mo is highest at the peak, then median, then the mean gets pulled lowest. Seeing where they fall relative to each other gives you clues about the shape of your data.
Let's focus on the mean again. Calculation is sum divided by count. Where else is it heavily used in healthcare admin or research?
Oh, loads of places. Budgeting relies on average cost per procedure or per patient day. Quality improvement tracks mean infection rates across different hospital wards, or mean time to treatment for conditions like stroke. Public health uses mean age of onset for diseases. That 2024 example of reducing mean ER wait time from 5 to 30 minutes, that's a classic quality improvement application.
But we need to remember that sensitivity to outliers.
Absolutely crucial. If you have data on lengths of stay like 2, 4, 6, 8 days, the mean is 5. Pretty representative. But add one patient who stays 100 days. 2, 4, 6, 800. Now the mean jumps to 24 days. That 24 doesn't really describe the typical stay for most patients in that group at all. The single outlier dragged the mean way up.
Which is why the median is often preferred in those situations. Remind us how to calculate it.
First, order the data, smallest to largest. If you have an odd number of data points, the median is literally the one in the middle. If you have an even number, find the two middle values and average them.
So in that skewed length of stay example, 2, 4, 6, 8, 100.
Yeah.
Odd number, 5 values. The middle one is 6, so the median is 6 days. Much closer to the bulk of the data than the mean of 24. If we had 2, 4, 6, 8, the two middles are 4 and 6, average them. Median is 5. See how the outlier of 100 didn't affect the median calculation nearly as much?
Makes sense. So besides length of stay, where else is median the go-to measure in healthcare? Income data in health equity studies is a classic example. I mean, income gets skewed by billionaires, Median gives a better picture of the typical person. Survival times in clinical trials are often reported as medians, especially if not all patients have reached the endpoint. Costs, definitely. Median cost is often more informative than mean cost due to high-cost outliers. A 2025 study using median ICU stay to optimize bed allocation is a perfect example of its practical use.
You mentioned robust statistics like trimmed mean earlier, too. What's the idea there?
They're designed to be less sensitive to outliers than the standard mean, but potentially use more information than the median. A trimmed mean, for instance, just lops off a certain percentage of the highest and lowest values before calculating the mean. Like a 10% trimmed mean removes the bottom 10% and top 10% of data points. The Huber-M estimator is fancier. It downweights outliers instead of removing them entirely. They offer a middle ground.
Okay, onto the mode. Most frequent value. You said it's best for categorical data.
Yeah, that's its main strength. Identifying the most common diagnosis code in a clinic's billing data, or the most frequent type of adverse event reported. A 2024 ER using the mode of chief complaints, like chest pain or abdominal pain, to adjust staffing makes perfect sense.
Does mode have limitations?
It does. Sometimes there is no mode. Every value occurs only once. Or you can have multiple modes, bimodal, multimodal, which makes it less useful as a single summary measure. And for continuous data, especially if measured very precisely, the mode might not be very meaningful because exact values rarely repeat.
Let's revisit the weighted mean. Formula. Sum of value times weight divided by sum of weights. Give us that HCA-HPS example again.
Right. HDA-HPS is the standard patient satisfaction survey. Hospitals get scores on different domains: communication with nurses, communication with doctors, hospital environment, etc. When calculating an overall hospital rating, CMS, Centers for Medicare and Medicaid Services, might assign different weights. Maybe nurse communication counts for 30%, doctor communication 30%, environment 15%, and so on. The final score is a weighted mean, reflecting that some aspects are deemed more critical to the patient experience.
And this affects real money, right?
Absolutely. Reimbursement is often tied to these weighted quality and satisfaction scores. A 2025 hospital improving its weighted score could see a 5% increase in funding, for example. So understanding weighted means is crucial for hospital administrators. And the methods get more complex too, like Bayesian weighted means that incorporate prior data, showing up in 2025 CMS models.
We talk about skewness affecting the mean, median, and mode. Can you visualize that relationship again?
Imagine hospital length of stay data. Most people stay a few days, but a few stay for weeks or months due to complications. That's a right skew, a long tail to the right on the histogram. In that case, the mean gets pulled way out into the tail by those long stays. The median will be lower than the mean, less affected by the extremes. And the mode, the most common length of stay, maybe 3 or 4 days, will be even lower, typically under the highest peak of the histogram.
So right skew, mean median mode. Left skew would be the reverse.
Exactly. Left skew, long tail low. Mode, median, mean. Knowing this helps you interpret your data. If the mean is much higher than the median, you likely have some high outliers or right skewness.
And if we have skewed data, besides using the median, what else can be done if we need to use methods that prefer symmetrical data?
Well, the trimmed mean we mentioned is one option. Another common approach is data transformation. Taking the logarithm, log transform, of each data point often pulls in that long tail and makes the distribution more symmetrical, more bell-shaped. Then you can analyze the transformed data. Windsorizing is another technique. Instead of trimming outliers, you cap them, replacing extreme values with the highest-lowest value that isn't considered an outlier. A 2024 study using log-transformed income for resource allocation is a good example of applying transformations.
Let's try another practical exercise idea for central tendency. What data could be used?
Okay, imagine a data set from a diabetes clinic. You have HbA1c levels, continuous, ratio, patient insurance type, categorical, nominal, and maybe their self-reported adherence to medication. Ordinal scale. Always, usually, sometimes, rarely, never.
What calculations would make sense?
For HbA1c, you'd calculate mean and median. Compare them, is the data skewed? Maybe calculate standard deviation too for spread. For insurance type, you'd find the mode, which insurer is most common. For adherence, you could find the median category, usually, and maybe the mode, always. You could then discuss why mean HbA1c might be useful for tracking overall clinic performance, but median might be better if a few patients have extremely high values. It reinforces choosing the right tool.
Perfect. Let's tackle our final module. Data validity and reliability, focusing on specificity. Why are validity and reliability the cornerstones of data quality?
Because without them, your data is potentially worthless or worse, misleading. Validity means, Are you actually measuring what you intend to measure? Is the data accurate? Reliability means, is a measurement consistent? If you measure the same thing again, do you get the same or a very similar result? You need both. Think of a blood pressure cuff. It needs to be valid, accurately measure blood pressure, and reliable, give consistent readings each time.
What happens if healthcare data lacks validity or reliability?
The consequences can be severe. Invalid diagnostic tests lead to misdiagnosis. Unreliable data entry in EHRs, maybe different nurses record blood pressure differently, leads to flawed analyses and potentially wrong clinical decisions. Errors, wasted resources, patient harm. It all stems from poor data quality. That 2024 hospital effort to standardize EHR inputs and boost reliability by 30% shows it's a recognized problem with tangible solutions.
Today's focus is specificity. Define that for us in the context of a diagnostic test.
Specificity is all about the true negatives. It's the ability of a test to correctly identify people who do not have the disease or condition being tested for. A test with high specificity is good at ruling the condition out. It minimizes false positives.
False positives being?
When the test says you have the condition but you actually don't, high specificity reduces those incorrect alarms, which saves patients from unnecessary worry, follow-up tests, and costs.
How do you calculate specificity? Can you give an example?
The formula is true negatives plus false positives. So imagine a new COVID-19 test. You test 1,000 people known not to have COVID. The test correctly identifies 950 as negative, true negatives, but incorrectly flags 50 as positive, false positives. The specificity is 950 plus 50 equals 950, 1,000 equals 0.95, or 95%.
So 95% of the time, it correctly says negative for people who are truly negative. When is high specificity most critical?
It's especially vital in screening programs for relatively uncommon diseases. If you're screening a large, mostly healthy population, you really want to avoid telling lots of healthy people they might have the disease, false positives. Think about cancer screening. A highly specific test minimizes the number of people needing invasive biopsies based on a false alarm. That 2025 AI mammography tool achieving 98% specificity and cutting false positives by 20% is a prime example of its importance.
The source material specifically asks for the definition. Let's nail that down.
Okay. Specificity is the measure of how well a test correctly identifies individuals who do not have a specific condition. It's the proportion of true negatives. High specificity means a low false positive rate.
Specificity sounds crucial, but it's often mentioned alongside sensitivity. What's sensitivity and how do they relate?
Sensitivity is the flip side of the coin. It measures how well a test correctly identifies people who do have the condition. It's the true positive rate. So sensitivity is about finding the cases, specificity is about correctly identifying the non-cases.
Do you always want both to be 100%?
Ideally, yes. A perfect test would have 100% sensitivity and 100% specificity. But in reality, there's often a trade-off. If you adjust a test to make it more sensitive, catch more true positives, you might inadvertently lower its specificity, get more false positives. If you make it more specific, reduce false positives, you might miss some true cases, lower sensitivity.
So it's a balancing act. How do we evaluate a test's overall performance considering both?
That's where ROC curves come in. ROC stands for Receiver Operating Characteristic. It's a graph that plots sensitivity, true positive rate, against 1 minus specificity, false positive rate, for a test at various thresholds.
What does the curve show you?
A curve that hugs the top left corner represents a better test, high sensitivity and high specificity across different cutoff points. A diagonal line from bottom left to top right means the test is no better than flipping a coin. We often calculate the area under the curve, AUC. An AUC of 1.0 is perfect, 0.5 is useless. An AUC of 0.92, like mentioned in the source, indicates an excellent diagnostic test overall.
Can you illustrate that sensitivity-specificity trade-off with an example?
Think about a rapid strep test in a doctor's office. It might be designed for high sensitivity to quickly catch most strep cases, but it might have lower specificity, meaning some viral sore throats might test positive. A throat culture, on the other hand, is generally highly specific, very few false positives, but takes longer and might be slightly less sensitive if the sample isn't perfect. The doctor weighs the trade-offs. That 2025 sepsis test balancing 93% sensitivity and 97% specificity shows how critical finding the right balance is for life-threatening conditions. Visualizing an ROC curve comparing two tests really helps understand this trade-off.
Given how vital validity is, what advancements are helping ensure data accuracy beyond just diagnostic tests?
Technology is definitely helping. In data analysis, techniques like cross-validation are standard for checking if predictive models are valid, basically, testing the model on different slices of data to make sure it generalizes well. AI, especially deep learning in medical imaging, is actively being developed to improve both sensitivity and specificity, pushing diagnostic accuracy higher. And those FHIR standards we talked about, they improve validity by ensuring data means the same thing when shared between systems.
Any examples of tech improving validation?
A 2024 hospital using AI to double-check lab results before they went into the EHR, flagging implausible results cut errors by 25%. That directly improves data validity. And a 2025 genetic testing validation study using machine learning achieved 99% specificity that's validating the accuracy of the test itself using advanced methods.
Let's bring back those case studies, AI mammography and sepsis detection through the lens of specificity.
Right. The AI mammography with 98% specificity. That directly meant 20% fewer unnecessary biopsies. Think about the reduction in patient anxiety, cost, and potential complications from those biopsies. It highlights how specificity impacts patient trust and well-being.
And the sepsis test.
The 97% specificity there means fewer false alarms in the ICU. Each false sepsis alarm can trigger a whole cascade of potentially unnecessary, resource-intensive interventions. High specificity ensures the ICU team focuses their efforts on the patients who truly are septic, improving efficiency and potentially outcomes for everyone. It really forces you to think about how you balance catching every case sensitivity versus avoiding false alarms specificity.
Finally, the outline mentions student research presentations on validity specificity. How does an activity like that deepen understanding?
It forces students to go beyond textbook definitions. They'd have to research specific diagnostic tests, maybe different COVID tests or types of cancer screening. They'd need to find the reported sensitivity and specificity, understand how those were determined, the validation studies, critically evaluate the evidence, and present the trade-offs. Discussing the real-world implications, the impact of false positives or negatives for that specific test, makes the concepts much more tangible and memorable. Peer feedback adds another layer of critical analysis.
This has been a really comprehensive look at managing and analyzing healthcare data. We've covered a lot of essential ground.
We really have. From the absolute necessity of informed consent and understanding HIPAA, to differentiating between categorical and continuous data and how that shapes analysis, then using measures like mean, median, and mode to summarize data, and finally grasping the importance of validity, reliability, and especially specificity for trusting our diagnostic tools. It's all interconnected.
And weaving through it all is the expertise from the source material by Dr. Salama, whose background as a data scientist, clinician, and quality expert really highlights how vital these concepts are for actually improving healthcare day to day.
Absolutely. His perspective really bridges that gap between the bedside and the database, showing the practical relevance of everything we've discussed.
So as we wrap up, maybe a final thought for everyone listening. We're generating more health data than ever. And our tools to analyze it, like AI, are getting incredibly powerful. How do we continue to strike that critical balance between using this data for good, improving health, efficiency, discovery, while fiercely protecting individual privacy and ensuring fairness? It's an ongoing challenge, and maybe think about what role informed individuals like yourselves can play in shaping that future.
That's a great point to end on. And if you want to dig deeper, definitely check out resources like the official HIPAA guidelines, look up some of the studies or concepts we mentioned in medical journals, or find good reviews on statistical methods in healthcare. There's always more to learn.
Thank you for joining us on this deep dive.